So good morning, good afternoon, and good evening, everyone. Thank you for joining us. It gives me great pleasure to introduce Professor Ralf Stücker to you, who he has been the Chief of the Pediatric Orthopedic Department at the Altonaer Children's Hospital since 1997. He's also the Professor of Pediatric Orthopedics at the University Clinic in Hamburg. His presentation today is going to focus on Prader-Willi syndrome and orthopedic problems, especially spinal deformities in PWS. So I'd like to welcome you, Professor Stücker, and thank you very much for joining us. And I'll hand over to you.
Yeah, good morning to everybody. It's a pleasure to be here together with you, although we cannot be there face to face. I think I hope it's maybe some of the stuff I'm presenting may be interesting to you, and we'll have some Q&A later. My topic is management of scoliosis and spinal deformities in patients with Prader-Willi syndrome. As you know, this is quite a big problem in patients with Prader-Willi syndrome. In a study of West and Belloc in 2004, they found an incidence, a prevalence of scoliosis in about 40% of patients, but they also found other orthopedic problems and manifestations like flat foot, hip dysplasia, osteopenia, kneecap problems like patellar instability, bow legs, and so forth. So my focus will be on spinal deformities today. And in another study by Nakamura, who looked at different papers on spinal deformities in Prader-Willi syndrome, they found a prevalence of 15 to 86% of scoliosis. And interestingly, they also noted a high incidence of kyphosis, which is a round back, of up to 40% in patients with Prader-Willi syndrome. And this is also our experience, that many patients with Prader-Willi syndrome and scoliosis also have kyphosis. This is different to the lessened idiopathic scoliosis, so the normal scoliosis. They almost all present with a flat back, not with a round back. In another study by Odent, which was published in Pediatrics in 2008, the authors found a prevalence of scoliosis of 43% below age 10, which increased to 66% at maturity. Most of the patients, as you can see, developed their scoliosis before age 10, which is also different to adolescent idiopathic scoliosis, because in that group, most of the children develop scoliosis during the adolescence growth spurt. So the overall risk of developing scoliosis before maturity in PWS patients is 60 to 70%. And interestingly, 23 of them develop scoliosis very early before age 4. In former times, that was called infantile scoliosis. Now we call that early onset scoliosis. And also interesting, those who develop scoliosis before age 4 all have profound hypotonia. Altogether, I think 15% of Prader-Willi syndrome patients will definitely require surgery for increasing scoliosis. And if we look at the literature, complication rate of surgery was reported to be high, up to 50%. And prevalence of scoliosis, what we know right now, is not affected by genotype, by growth hormone treatment, by age, sex, or BMI. So what are the treatment strategies for scoliosis? Of course, they are not very much different to other forms of scoliosis, like neuromuscular scoliosis, syndromic scoliosis, and so forth. And we can divide that in age groups. If we look at patients less than 5 years old, casting and bracing are very good options. Between the age of 5 and 10, bracing for moderate curves and growing rods for increasing curves are very valuable. And above age 10, the definite spine fusion needs to be considered. I will also talk about a new treatment method. It's called vertebral body tethering, which is now rather frequently applied to patients with adolescent idiopathic scoliosis. So what is casting? Casting means you put the patients, the little patients below 8 years, you put them under anesthesia on a special table. We call that a RISA table. And then under traction, a cast is applied. And this is repeated at least 3 times. There are other treatment protocols, for instance, in other centers who use the casting for 2 months and change it 3 up to 8 times and put that on for 1 or even 2 years. Our protocol is we change it every 4 weeks, do it 3 times, and then it is replaced by a brace, as you can see on the right side. So this is what you need, a special table, and this is how it is done. It's just well padded, and then the cast is applied under anesthesia and traction. This is an example of a 2+5-year-old boy who got 3 casts. He presented with 42 degrees of scoliosis, and after the 3rd cast, it was reduced to 15 degrees of scoliosis. And here on the right-hand side, you see the typical plaster, how it looks. There is a nice study which was published in JPO this year by a group of Philadelphia from Shriners Hospital. And they looked at 37 patients with Prader-Willi syndrome below age 5. 34 of the patients had a follow-up of more than 2 years. All received growth hormone treatment, and the average age at the beginning of casting was 32 months. And what they found is, of these 34 patients, 12 were cured by the casting, 18 had to be braced, and 4 needed surgery early on. And these are examples which I picked from the publication. You can see here a scoliosis, which was treated by a cast, and then 2 years follow-up, it was almost straight, though that was cured. And this is another patient with a more severe scoliosis in a cast, not completely straight, and then the follow-up in a brace. And what happened is no cure could be seen, but at least it was kind of a time-buying strategy to get the patients older to above age 5 and more, so that you don't need to do surgery very early. And those who had scoliosis of less than 50 degrees and were very young, so less than 3 years of age, had the best prognosis. Clinical examination usually is pretty much straightforward because you can see the asymmetry of the shoulders, you can see the rib hump over here and the asymmetry over here. This is not so easy, not so difficult to detect. Also here with the Adams forward test and the scoliometer, you can really see that there is an asymmetry with the rib hump over here. So this is easy to detect by clinical examination. However, in obese patients, like you can see over here, diagnosis by clinical examination may be very difficult. And therefore, it is sometimes undetectable, and to detect early onset of scoliosis, X-ray may be necessary. Well, what about brace treatment? This is a typical brace, and as you may know, a brace is applied for many patients with adolescent idiopathic scoliosis. And this is from the so-called brace study, and you can see here the hours per day in brace, and here you can see the percentage of success. And in adolescent idiopathic scoliosis, you can clearly see the more you wear the brace, here it's about 18 hours, the higher the success. Well, this has not been shown to be true for patients with Prader-Willi syndrome, and especially not true for patients who are obese, because the brace, as you can imagine, is not working well for obese patients. Well, let's go to the the age above 5, so in between 5 to 10. And at that age group, casting, like I showed, cannot be applied that easily anymore because the patients are too big to apply the cast. And in this age group, a brace may still be an option, but from more established curves, growth-friendly surgery may have to be considered. Growth-friendly surgery, that means that you put in some hardware devices, you straighten the spine, but you are still able to grow, and so you don't fuse the spine very early. And there are certain different options available, like a Vector and a TG. I will show you in a minute how that looks like. And this is a study who looked at patients with Prader-Willi syndrome and who received these growing rod treatments. And you can see it's a moderate correction. The mean scoliosis was 76 and was corrected to 42 degrees, and the kyphosis was also somehow corrected from 59 to 54 degrees. But many of them had complications. You can see of these 13 patients, 85% had complications, and 2.2 complications were detected per patient. So this is quite a significant number of complications. So this is a growing rod treatment in a 9-year-old boy with scoliosis and Prader-Willi syndrome. This was 56 degrees, so a moderate curve, which couldn't be controlled by a brace anymore. And you can see here, this is a growing rod. There's some implants over here as an anchor, some anchors over here, and in between there are rods. And this is a telescopic device. And this telescopic device had to be opened every 6 months by a little surgery and was lengthened so that the growth was preserved. Most recently, we have another option, which are the magnetically controlled growing rods. And you can see here again a moderate scoliosis, and you can see the growing rods, anchors over here, anchors here. And in between there are rods, and inside the rods there are magnets. And those magnets can be turned on by an external magnet and can be lengthened without surgery. Again, 5-year-old patient, a girl with a Prader-Willi syndrome scoliosis of 64 degrees, and she was treated with these magnetically controlled growing rods. And this is how it works, the lengthening. The patient comes back to our institution every 4 months, and then the lengthening is done with an external device. As you can see over here, they are lying prone on the table, and then the magnets are lengthened. You can see here 2 millimeters on that side, and then the other side is lengthened. And that works quite well. It is not painful, and the patient do tolerate that very well. So what about scoliosis of when the patients are more than 10 years old? Still, a brace can be used for moderate scoliosis. Growing rods can still be used if the sufficient growth is remaining. For some patients with little growth, final fusion probably has to be selected. And correction could be done with a VBT. I will show you in a minute what a VBT is. Again, this is a 16-year-old boy with Prader-Willi syndrome scoliosis. There's no growth remaining, so this one is at the end of growth, moderate S-type scoliosis over here with also some significant kyphosis over here. These are the bending films, and this is the final result, how it is usually done in a spine fusion for patients with Prader-Willi syndrome. Well, let's talk about complications, and there are some studies available who show a high incidence of complications in scoliosis surgery for Prader-Willi syndrome. Like this one here in 2008, they looked at 16 patients with spine fusion, average age was 12 years, and of those 16, 6 had major complication. and 4 were related to the kyphosis the patient had, and they developed proximal junctional kyphosis. I will show you what that is. Also, 2 developed deep infections, which in the past was also a major problem when you treated patients with Prader-Willi syndrome for scoliosis. However, in a recent study, which is a multi-center study, which was just published, the authors didn't find any big difference between complications between Prader-Willi syndrome patients and adolescent idiopathic scoliosis. The only difference was that the patient with Prader-Willi syndrome developed more postoperative pneumonia, and some of them also developed implant-related complications. This is a typical patient with the Prader-Willi syndrome, and it's a 10+6-year-old, and you see the scoliosis over here, but note the severe kyphosis over here. And in the past, we didn't really understand what the significance is. These are the bending films on the right-hand side, and then the patient was treated with the magnetically controlled growing rods, and that was immediately after surgery. It's very nice. The scoliosis is corrected, the kyphosis is corrected. But when you look 4 months later, what you see here at the top, the patient developed what we call a junctional kyphosis, a proximal junctional kyphosis, or PJK. So they develop additional kyphosis, and you see where the head is. It's completely leaned forward. That's not really what you want. Again here, 1 year postoperatively, severe junctional kyphosis, the head is somewhere over here, severely leaned forward, and that had to be revised later on when the spine fusion was done, and the high fusion up to the first thoracic vertebra had to be done, so the head is somehow back in the original position. So what is VBT? That means vertebral body tethering. And this is a non-fusion treatment. So the vertebrae are not fused like in spine fusion, and motion of the segments is preserved. And this is how it is done. You see the application of screws into the vertebra, and this is a cable, elastic cable, as you can see over here. And so the cable is tensioned here on the convexity. That means this convexity is set under compression, so that there's little growth over here, but much more growth over here, and then it slowly straightens out. And that really works. As you can see here over here, this is not a Prader-Willi syndrome patient, but you can see the scoliosis over here. And you see how the screws are put in, and then 12 months later, the spine is straight. It really works, and but the only prerequisite is that you need enough growth, remaining growth, so that the spine can straighten out by growth. However, at this time, there's almost no experience in patients with Prader-Willi syndrome. Maybe if you have questions, we can talk about that during the Q&A session, right after my presentation. So the problems related to spine surgery in patients with Prader-Willi syndrome are kyphosis. And currently what we do for the severe kyphosis is we try to stretch it out by gravity traction. Another problem is the ligamentous laxity. And ligamentous laxity means that you have to do longer fusions, and you should better not stay short, so that the fusion goes longer into the lumbar spine. You have to fuse more segments into the lumbar spine. And another issue is decreased bone density. Sometimes the bone is very weak, the bone density is low, and you need more implants, and implants may get loose, and this is also typical for patients with Prader-Willi syndrome. But with more implants, more screws, you can distribute more forces, and loosening of screws is typically not a major issue in modern spine surgery. So this is halogravity traction. What does that mean? You see that traction is applied here with this little boy here to the head. The ring is applied to the head, and then traction is applied 24/7, so 24 hours a day, and for the whole week, and typically for 4 to 6 weeks. And you can see here how that works. This is a patient with Prader-Willi syndrome, 5 years old, severe scoliosis, also some kyphosis over here. And this is after 4 weeks of halo gravity traction. The kyphosis is stretched out, so almost no more kyphosis. And then after 4 weeks, the growing rods were applied with a very good result. Kyphosis is stretched out, no proximal junctional kyphosis. Another patient with a Prader-Willi syndrome and with a severe scoliosis of 120 degrees. That is really excessive. Also severe kyphosis, 80 degrees. 4 weeks of halo gravity traction, you can see how the scoliosis is stretched out, how the kyphosis is much better than it was. And this is then the final surgery or spine fusion with no proximal junctional kyphosis. So halo gravity traction really works very well. It is not as bad as you would think because patients do tolerate that very well. What about growth hormone treatment? There are many discussions in the literature going on about growth hormone treatment and incidence of scoliosis. And this year there was a work from Grotjen, and they looked 10 years back, and they compared the group of Prader-Willi syndrome patients with patients who were not treated with growth hormone, and they didn't find any differences. The prevalence of scoliosis was 77%, and there was no difference between patients who had growth hormone treatment and without growth hormone treatment. They also found no difference in the severity of the scoliosis compared to untreated children. And but a major finding in their work was that higher bone mineral density, so stronger bone, was associated with lower degrees of scoliosis, lower corp angles. This was a randomized control study. You're probably familiar with that study. And they looked at 91 children with Prader-Willi syndrome. The median age was very low. And they also didn't find any difference between patients who had growth hormone treatment and no growth hormone treatment. And they concluded that scoliosis should no longer be considered a contraindication for growth hormone treatment in children with Prader-Willi syndrome. And this is what I tell all patients with Prader-Willi syndrome and developing scoliosis. So as a conclusion and as a summary, yearly spine exams are necessary. And in case of obesity, it is probably worthwhile to obtain X-rays. If scoliosis is developed early in life, below age 5 years, a casting is a very effective treatment to cure or to halt the progression of the scoliosis. Between age 5 and 10, growth-friendly surgery is recommended for scoliosis above 50 degrees. For severe scoliosis of more than 70 degrees and significant kyphosis, halo traction has been found to be very effective. We have currently no experience with a VBT method for patients with Prader-Willi syndrome, but it may, or it can be, probably in my opinion, it can be applied for selected patients. And spine fusion at maturity, in our experience, is not associated with increased risk compared to idiopathic scoliosis. So these are greetings from Hamburg, and I'm waiting for your questions. Thank you very much.